And we are back. Welcome to another exciting edition of Keys to the Cart. My name is Dr. Ali Bechtel. I'm an anesthesiologist at the University of Virginia, and I am so excited to be here once again with Dr. Sunny Chow, a fellow anesthesiologist, as we get ready to unlock some knowledge and review some more keywords. Hi, Dr. Chow. We have been having some intense conversations about maternal ACLS and resuscitation.
Yes, we have. What do you say we talk about something a little lighter today?
That is a great idea. I thought that we could review ERAS for C-sections.
That's a great idea. This is definitely a newer topic. We've only been doing ERAS, or Enhanced Recovery After Surgery, for a cesarean section since February 2016 at our institution, and it is definitely a lighter topic. ERAS for C-sections is a pathway that guides management for pregnant patients who are scheduled for elective or sometimes urgent C-sections, including guidelines for the preoperative, intraoperative, and postoperative management.
So let's get started with preoperative preparation and management. One of the important components of any enhanced recovery after surgery programs includes giving the patient information before the surgery so that patients know what to expect at every stage of the procedure and hospital admission. And obviously, this will vary depending on the indication for the C-section, whether it is scheduled or unscheduled. In addition, there are several maternal disease states during pregnancy that require appropriate management and planning, and these include maternal obesity, maternal hypertension, maternal gestational diabetes, maternal anemia, and maternal tobacco smoking use. Next up, for preoperative preparation, patients should receive antacids and histamine 2 blockers to decrease the risk from aspiration of acidic gastric fluids. And patients should not receive any preoperative sedation since this may have negative effects on the mother and the neonate.
There always seem to be questions about preoperative NPO status, so let's set the record straight. There's no need for a bowel prep prior to C-section. In addition, a light meal may be eaten at least 6 hours before a scheduled C-section, and pregnant women should continue to drink clear liquids up until 2 hours prior to a scheduled section. We often recommend Gatorade or some form of clear oral carbohydrate fluid for our patients who don't have diabetes to be consumed up to 2 hours before C-section.
Now that we have covered the preoperative recommendations, let's move into the OR and get the patient ready for the C-section. Within 60 minutes of incision, make sure that your patient gets a first-generation cephalosporin for antibiotic prophylaxis. There is also evidence that patients who come to the OR following labor or with ruptured membranes may benefit from azithromycin antibiotic prophylaxis with decreased postoperative infection rates. Thromboprophylaxis is another component for intraoperative ERAS that involves placement of pneumatic compression devices for all patients. The anesthetic technique is also an important consideration for enhanced recovery, and regional anesthesia absolutely is the preferred method. We know that hypotension may accompany a spinal anesthetic for a C-section, so it is important to monitor blood pressure carefully and avoid hypotension with the use of a phenylephrine infusion and a fluid co-load of up to 2 liters crystalloid IV fluids. Now, if there is one thing that I really do not like, it is being cold, and for our patients who are having a C-section, avoidance of hypothermia is so important. So make sure that you are monitoring the patient's temperature, as well as keeping the room and IV fluids warm, and that you have warming devices available.
Now that everyone's nice and warm, let's take a minute to review important considerations for the neonate immediately following delivery. Cord clamping should be delayed for at least 1 minute following a term delivery and for at least 30 seconds following a preterm delivery. And do you know who else shouldn't get cold in the OR? It's the neonate, whose temperature should be kept between 36.5 to 37.5 degrees Celsius. In addition, routine suctioning and supplemental oxygen administration should not be given unless there is a clear indication, such as the presence of secretions or meconium. Finally, if you are at a hospital that performs C-sections, there is a requirement for the ability to perform neonatal resuscitation if needed following delivery.
Another consideration for an ERAS C-section is PONV prophylaxis. Strategies for PONV prophylaxis may include IV administration of dexamethasone and ondansetron. Other therapies may include treatment to prevent hypotension with the phenylephrine infusion, IV administration of metoclopramide, and minimization of uterine exteriorization if possible. Skin to skin between the mother and neonate is important, as well as early attempts at breastfeeding if desired. Following delivery, IV oxytocin as an infusion for prevention of postoperative hemorrhage should be administered. And at lower doses, adverse side effects such as hypotension and myocardial ischemia are less common.
Finally, let's review some of the components of postoperative ERAS care. Early oral intake is safe and beneficial for early return of bowel function and early ambulation. Postoperative pain management should include scheduled oral multimodal analgesic medications, including acetaminophen and nonsteroidal anti-inflammatory medications. Patients who do not receive intrathecal morphine may benefit from local wound infiltration and transversus abdominis plane, or TAP, blocks, and quadratus lumborum, or QL, blocks. The final steps include early removal of the Foley catheter and early mobilization.
What a great review of the important components for an enhanced recovery following C-section protocol. Does your institution have an ERAS program for C-section?
I'm glad that we have one at UVA, and I'm looking forward to my next OB anesthesia day. Since I know that I'll be back covering OB again soon, I thought that we could continue to review OB keywords next time.
That is a great idea. And if you have a favorite keyword that you would like to hear about on this podcast, please email us at keystothecart@gmail.com. Or you can find us on Twitter at keystothecart.
Thanks for listening, and tune in next week as we hand over the keys to the cart once again.